everyone, and welcome to the Breathe California educational podcast series. My name is Aisha, and I'm the Communications Director here at Breathe California Golden Gate Health Partnership. As a local organization that fights lung disease, advocates for clean air, and advances public health, Breathe California began as the TB Society over 100 years ago. Today, Breathe California continues to fight tuberculosis in our communities. With World TB Day approaching, we focus our podcast on the current TB climate in California. California has the highest number of TB cases in the nation, making it an important area of lung health for us to continue to address. Despite the considerable progress in controlling TB cases, we must remain persistent. Joining us today is Dr. Julie Higashi M.D., Ph.D., President of the California Tuberculosis Controllers Association and TB Controller. Thanks for sharing your time with us today, Dr. Higashi. Can you tell us a little bit more about your work as a TB controller?
My job is to make sure that everybody in San Francisco who has tuberculosis or has been exposed to tuberculosis or is suspected of having tuberculosis is getting the right evaluation and treatment for their TB.
Why is tuberculosis still a concern in the community today?
TB is still a concern because it is still a disease that kills over 1 million people a year, and it really isn't a disease that we see a lot in the United States, but it's still here in the United States. And the reason it's still here is because we have a lot of open doors to global travel, and we have pockets of people who are more susceptible to TB and where TB can be transmitted from person to person. So until we really get rid of TB in the entire world, it's always going to be a concern.
Who's at risk of getting exposed to tuberculosis, and how is it transmitted?
Because of the way that TB is transmitted, it's an airborne disease. If you cough, then you create these infectious particles, and you're sharing the airspace with a person who has active TB. That's when those people can breathe in the particles and then become infected. And so one thing that has always struck me about tuberculosis is that it is really a disease that has no boundaries because of the way it's transmitted. And so we see people from all over the world, but also people who are U.S. citizens who have never traveled anywhere.
Due to the highly contagious nature of TB, is it managed with a separate healthcare system?
Because the TB can be spread this way, and it really doesn't require any sort of consensual activity. It's just breathing the same air. The public health system has a system in place in order to monitor TB. And I think this is one of the original reasons why public health developed to begin with, was to actually address tuberculosis. It's not really a separate health system, but it's all part of the public health safety net that is in place that's we like to have remain invisible, but it's taking care of the population. And so there's food safety, for example, and then there's communicable disease safety. So folks who are exposed to a disease may get a call from their health department to be evaluated, and that's what the system that I'm talking about is in place, because that's the same system that we have for TB. And it really is a place where we're not just thinking about the individual patient, but the population. So we're tracking the number of cases, we're making sure we're getting into the communities after there's been an exposure to evaluate everybody who's been exposed or had what we think is a significant exposure to tuberculosis. Those are some of the examples of what we do. We make sure that everybody has medications and the right medications, that they're completing treatment. And it takes staff to be able to do this. We also have some tools that other folks don't have, like legal authority to really compel people to adhere to treatment. And we'd like to think everybody is going to be on board with being treated for TB, but sometimes there are other complicating factors like mental illness or substance abuse, which makes it very difficult for people to understand why they need to be on medication. And so that's when you need a field worker to be going out and looking for somebody every day to give them their medications, because they don't have the ability to come into the clinic regularly. We have people doing that all the time. And it's with that focus on every single person, looking at the big community, that we are successful in keeping TB under control and getting those numbers down.
Could you share an estimate of the recorded cases from last year?
As a city in San Francisco, we reached an all-time low in 2010 with 98 TB cases. And over the last 2 years, we've seen, for the second year in a row, an increase in TB cases. So their number was 116, which really doesn't sound like a lot, and numerically it really isn't. Relative to the total population of San Francisco has one of the highest TB rates in the country. So we know that because of our population, we have a lot of people who have TB infection. We estimate 1 in 12 San Franciscans has TB infection. So that pool are our potential future cases. And the fact that we're now seeing a rise in cases over the last 2 years is really something we really need to be wondering, okay, what's going on here? And because we now have a trend of 2 years, our early assessment is that there is really no particular group. We don't think there's an outbreak going on in San Francisco. And so our concern is we're just not getting to our cases as quickly. We're not locating our suspects as quickly. So when a hospital says, oh, this person, we weren't able to keep them in the hospital, we're worried they have TB, can you help us find them? Then it takes us a little bit longer to find them. There's an opportunity for that TB to be spread in the community. So that is our concern, and we're really, really trying to understand what is the reason for this increase. And at the same time, we're trying to prioritize as much as possible how we use our resources so we can make the biggest impact. And so that's what we're busy working on right now.
What are your most pressing concerns in the way that TB is being addressed today, and what developments would you like to see?
We're at a crossroads in TB control and elimination with the current funding environment. And I am worried that we're going to see history repeat itself if we don't maintain the necessary infrastructure for this public health system that has been very successful at reducing TB numbers in the last couple of decades. In the 1970s and 80s, funding for TB really disappeared. And that, together with the HIV/AIDS epidemic, created a situation where TB became an epidemic in the United States. And drug-resistant TB was rampant in New York City. And it really took 20 years to get back to where we were. It took 10 years for the epidemic to develop and 10 years to get on top of the epidemic. And so we lost 20 years of time where we could have been further ahead than we are now in just getting rid of TB in general. New York City spent $1 billion recovering from that epidemic. And in San Francisco, we've calculated that we spent $55 million, extra dollars that we didn't need to spend if we had spent a little bit up front to just maintain the infrastructure. So there's a lot to be hopeful for, because with better diagnostic tests, with better treatment for infection, there's some new drugs out now for drug-resistant disease. I really feel like we have an opportunity here to take TB elimination to the next level if we're able to harness the opportunities that the Affordable Care Act has with better opportunities for prevention. We don't have to go back and repeat history. We could actually take this moment with a little bit of support and carry it to the next level, and therefore prevent more costs downstream.
You mentioned a little bit ago about the Affordable Health Care Act. How will TB management be affected by this act?
It's a good question, because I think a lot of us don't understand the full impact of the Affordable Care Act. But our best guess is, our hope is that this is going to be an opportunity for tuberculosis. I think it's going to be great that many people will have medical homes where they can receive preventive services. Right now, one of the challenges is that there is a sort of administrative loophole that doesn't allow TB to be part of the package of preventive services. So if a patient goes to their physician, they may have to actually have an out-of-pocket cost to be screened or treated for the TB infection. And we're working really hard at the California TB Controllers Association to change that and to make TB a prevention activity. So that's one of our challenges, but I still think that more people will be able to go to their physician, and with better support of physicians in the community, we can get more people screened and treated so that they don't develop the active disease, but that we can get in on the infection part, which is much easier to treat. One of the things that I think that the Affordable Care Act does not provide for is to maintain the separate health system that we discussed just before this to support TB control in the community. So we'll still need to have workers who can actually do the field work, and really these are workers who go to populations that can be difficult to access, for example, the homeless population, and they just make sure that those folks get what they need in order to complete treatment. And so those are some of the basic aspects of TB care. I think another one of them that I haven't mentioned is for a number of people, because of the side effects that can happen with the TB drugs, we want to see some folks every day take their medication for two reasons. One, to make sure they're taking their medication, but on the other end, to make sure that they're tolerating their medication. So if somebody is going out every day, or the patient is coming into our clinic every day to take medications, that allows us to really monitor very carefully how they're doing on their medications, and that they're going to not have a bad side effect or a bad outcome because the medication is creating a problem. So being able to have the structure to provide those services in the field and in the clinic is really important. And the Affordable Care Act doesn't really take care of that piece. So we need to keep our TB home intact in order to be able to provide the services to the other parts of the healthcare system.
Thanks again, Dr. Higashi, for sharing your time with us today. This concludes our podcast. Do you have any closing words to share with our listeners?
I think it's really a time where we need to look at what's happened in the past and evaluate and create the situation where we can move forward and be successful in eliminating TB.
Thanks for tuning in to our podcast today. If you'd like to stay updated, you can visit ggbreathe.org and tune in to our upcoming podcasts.